Good morning, everyone. Thanks for joining us for the Quality and Safety web-based elective. This is the first time we're running this elective, and we're really excited that you decided to join us. I'm Dr. Dutta. I'm the course director. And for our kickoff lecture, I'm excited to introduce Dr. Ansel. He's the Senior Vice President of System Integration at the Rush University Health System and our former Chief Medical Officer at Rush University Medical Center. So without further ado, I'm going to hand over the mic to Dr. Ansel, and he's going to talk about the patient safety imperative.
Thank you, Nina, and thanks to all of you taking this elective. And today I'm going to talk about patient safety, and you can follow along in your presentation. The learning objectives for this module is 1, to understand the safety imperative in healthcare, why it's important. 2, what is the language or the lexicon of patient safety? And we're going to go over some different common terms that are used in patient safety, from error to unsafe acts to harm, and you can see them listed here. 3, understand that 6 interacting sources of error and harm, that there's a structured approach to actually analyzing when things go wrong. Identify the common hazards in patient care, and then get into the analysis of events to identify root causes and contributory factors. And one of the big pieces of this that you're going to learn is really be able to distinguish between things that are called system-based factors and human factors. And that's going to be the major dividing point we're going to be thinking about. Understand this concept of normalization of risk, and understand what we mean by the words just culture. So why worry about patient safety? In the year 2000, it's almost 16 years ago now, it's actually exactly 16 years ago, the Institute of Medicine came out with a report that said as many as 98,000 people die in any given year from medical errors that occur in hospitals, and that's more than die from accidents, breast cancer, AIDS. And this is a giant deal in healthcare. And in 2013, a recent analysis estimates that over 440,000 deaths per year for harm occurred due to healthcare. So this is a big deal and why we should be concerned about it. And a simple way to think about quality and safety is obviously quality and safety occur around the same patient. But quality is everything that should happen for the patient actually happens. So if we're supposed to get it right, we get it right 100% of the time. And that's what we mean with quality. The other word that's often used is high reliability. So when we think about high reliability systems, that a patient should expect when they have a certain illness that all the right things are going to be done at the right time. And that's what we mean by high reliability. And the measure of that is something we call quality. But safety is everything that should not happen to the patient does not happen. And so in the process of providing care, we do not want to cause harm. So a misdiagnosis of cancer on an x-ray, the cancer was there, it wasn't seen when somebody read the report or the radiologist didn't see it and it was there, that can cause harm. Or a central line infection. Patient comes to the hospital, they have a cancer, they get the treatment for the cancer, but they get an infection because someone didn't wash their hands. That's harm. And we would like there to be zero harm in the hospital. So let's do some definitions now. So we're going to talk about the language of patient safety, or the lexicon. So there is a language here, and you should really know the differences between these different words and what they mean. So an error is defined as the failure of a planned event to be completed as intended, or the use of a wrong plan to achieve an aim. So imagine that an antibiotic's been prescribed and it's the wrong antibiotic, or the right antibiotic's been prescribed and the nurse hangs the wrong antibiotic. So an error may be caught before it reaches the patient, in which case it would be a near miss. If the other nurse at the bedside going over the 5 rights, is it the right patient? Is it the right dosage, this is the right medication, would pick up that and say, oh my gosh, we almost gave the wrong antibiotic, that would be considered a near miss. An unsafe condition indicates circumstances that increase the chance of harm. It could be, for example, a slippery bathroom, lots of interruptions during the procedure, inadequate staffing. Let's say the pharmacy wasn't staffed in the place where they were doing antibiotics. They end up in a rush and they mislabel. That could create an unsafe condition for a patient down the road. That's very different from an idea called unsafe act, which indicates that performing an action in a manner that poses risk to a patient or staff. In other words, a deliberate action that someone walked in a room and changed the dressing, didn't wash their hands, or infection control procedures were on the door, or someone didn't do a timeout during a surgery. But an unsafe act could also be a behavior. Someone who's dominating, not listening, could, in certain circumstances, be considered an unsafe act. So now we're going to talk about the language of patient safety, because this lexicon is important for every healthcare worker to understand. And you can use a simple algorithm to define events in near misses. So the first way I want to orient you is to the idea on the left that these are harm to the patient or no harm to the patient. And it's really important to understand this, that there are errors that are going to occur, but the big question is, are patients harmed? So let's deal with the top box first. So if there's harm to the patient, what you want to ask yourself, was there error that occurred that caused harm to the patient? So let's say the wrong antibiotic was given and the patient had an allergy to this and they went into anaphylaxis. That would be considered an adverse event, that there was an error in care and harm occurred. But let's say there was no error in care, that the right antibiotic was given, but the patient actually had a reaction, and that wasn't previously known. So there was no error because the right antibiotic was given, but the patient experienced harm, so that would be considered an adverse outcome. It wasn't expected, it wasn't anticipated, it wasn't something we could have known in advance. Now let's take the box below. There's no harm to the patient. So when there's no harm to the patient, the question is, was there an error or an event that occurred? And the error would be, for example, maybe you gave the wrong antibiotic to the patient. That was an error, but there was no harm to the patient. So that would be important to know. But the other way to think about it, there could be no harm to the patient, but there could be unsafe conditions. So let's say the staffing was short. A nurse had to pick up an extra patient, and that led to the delivery of an antibiotic. So there's no harm, but the conditions were there that raised the risk that harm could have occurred. And so it's really important to understand unsafe conditions, because if you can begin to understand unsafe conditions, you can see how you can prevent harm from the patient. So, but if there's an error that did occur, was it caught before it reached the patient? It's a near miss. And if the error reached the patient, it's an incident without harm. So if the antibiotic gets to the patient and the patient didn't have harm, then it's an incident without harm. If it's caught before it reached the patient, it's a near miss. But if there's no event, and we'll get really good, like I said before, if there's no event and we can appreciate unsafe conditions, that's sort of where we want to be in the world. So there's not only no harm, but we're treating the unsafe conditions that lead to harm. So there are 6 ways to think of interacting sources of error and harm. And if you can organize yourself around these 6 categories, almost in any event that occurs, you can place the what happened into one of these 6 categories. So there's human factors, and we're all human, and we're all able to make mistakes. Forgetting to check pending labs. Ordering the wrong medication after being up all night because you thought it was the right medication, was the wrong one. Making the wrong diagnosis because your brain was thinking so sure that X was the right diagnosis when it was really Y. In experience, you just don't have the knowledge to know the difference between A and B. Uh, Tackling something unfamiliar or under time pressure where you can make a mistake. Distractions, interruptions, pagers going off, doing too many things at a time, multitasking, and then fatigue. You walk by an alarm, you don't pay attention to it, and one time it's real. System process design could be things like there's not an attending in house, the attending doesn't answer their page, the ICU is filled, someone's in the wrong ICU, the alarm systems don't work to the degree that you want them to. Administrative controls. So there's a policy that's been violated, or there's no standard operating procedures around something. There's not proper training. So when people come in the door as a resident or an intern or an attending, they don't get the proper training in advance of taking care of patients. Central line would be a great example of being trained on an ultrasound before you put a central line in. Not knowing who's privileged. There are hazards. So hazards are things like a hazard is something that can risk of immediate harm to a patient. So think about this: a sharp or a staff member, a needle left in a patient bed, an unlabeled medication, insulin, where the dose on the vial may vary by different vials. I say anything that comes near a patient that you either put in them, like a line or a pill, is a potential hazard. Some people actually think interns and medical students are hazards, but I don't think that way. There are patient factors, multi-organ dysfunction, anatomy, wrong. Think about situs inversus, right? You can make all kinds of mistakes if you don't know the patient has situs inversus. Take the gallbladder out on the wrong side, for example. Patient preferences for care, and just rapidly evolving complex cases make things really, really hard. And then there's culture. So this is what I say: what we tolerate, we promote. Is tolerating deviances from norms. So if you walk in the room, medical students, and the attending physician doesn't wash their hands and you don't feel you can say something to them, that's culture. Even though we know washing hands is important. Not holding people accountable who violate policies and procedures. People showing up late, not showing up at all, attendings who don't answer their pagers, not speaking up. So this is a big deal in medicine, and it's a very big deal when you're at the bottom of the totem pole, to be able to know that on behalf of patients and patient safety you have to speak up. Yet it's almost the hardest thing to do. And not reporting near misses, because it's only if we report hazards and near misses will we actually ultimately be able to prevent events from happening. I can give you an example from Rush many years ago. We were having a series of retained foreign objects. These are sponges left in after surgery by the best surgeons in the country. And when we went back on it, we realized that there was not a standardized way to count. That in one room they counted sponges one way, in another room they counted it a different way. So we came up with a standard approach to counting sponges. But then we had to make reporting on failure to count correctly a near miss. We had a situation a number of years ago where people were going to the operating room without ID bands on. Or they went with an ID band on, and because they were doing surgery on that site, the anesthesiologist would cut the ID band off. They got to recovery room, no ID band, and the patient's unconscious. Obviously unsafe condition, and we made the reporting of absent ID bands a near miss. And the importance of reporting near misses is you can then understand what you had to do to fix the system. And now in the operating room, when you guys do in the operating room, I hope you saw that they did the thing: is this the right patient? Do they have the ID band on? was a systematic fix that was put onto that set of near misses. By tackling near misses, you can avoid down the road harm to patients. So I'm going to talk a little bit more about these 6 interacting sources of errors and harm. So number 1 is there's human factors. Humans make errors when tired, sleepy, stressed, distracted, or preoccupied, which sounds like every medical student and resident in the world. Humans make even more errors when working in poorly designed environments with poorly designed equipment or devices, or with non-standard procedures. And this is a big factor. And that's this idea here is being situationally aware of the environment you're in when you walk into it for the things that you have to do. There's cognitive biases. For example, it's called anchoring. It can lead to diagnostic errors. I presented a case last year of missed hyperthyroidism. And we missed hyperthyroidism in this patient. Had to be 100 Rush doctors, medical students, nurses, actually Rush and Oak Park, who missed it because this woman had traveled from Africa. She was an African woman, American citizen, who visited Africa and felt warm, and everyone thought she had malaria, and they couldn't get off the idea that she had an infectious disease, when indeed she had something quite common, hyperthyroidism. So we can all be led down the garden path by what our brains tell us. And human factors interact with system factors, poorly lit care areas, poor processes and procedures, and can lead to harm. System, process, and design is how are we organized to take care of patients. So this is how we design a building, an office, a workspace. What are the available resources, etc. Administrative controls, management practices. What do we do when something, let's say staffing is low, can we go up the staff? Going up, what's the process if the house is full and we have the next patient? What happens when you need an ICU bed and we don't have one? So these are the processes things. Some of these are credentialing and privileging. What are you able to do, and how do I know it? So a nurse at the bedside, you walk in, they don't know what you can do. Do they stop you and check what your privileges are? Problems with administrative control can manifest themselves as policy violations, and this was by asking the question why, not providing task-specific training. And so, someone walks to the bedside and say, I'm going to do a procedure, said, well, are you privileged? Why are you doing this? And getting underneath those types of things. Not supervising, so lack of supervision of junior staff, or not controlling who can do what is a potential source of harm. And this is how management decisions can affect these. And let's say the staffing levels. There's a fact about healthcare disparity in this country. Probably has little to do with the genetics and biology of the backgrounds of poor patients, but more to do with the fact that in some institutions that the staffing is such that when a patient goes bad, the staff is not there to rescue them. And that has led to differential mortality rates between institutions. So administrative controls are a giant deal, and we sometimes don't pay attention to them. Hazards, we talked about patient factors. We talked about a little bit sicker patients are more vulnerable from harm from medication. Depending how frail the patient is, you may not have a lot of leeway in making an error that causes harm. And then culture is the really thing. Okay, these are the rules. Yeah, these are the rules, but this is actually how we really do it around here. So if the culture allows, says speak up, but if you speak up, you get punished for it, either directly or indirectly. The next time it happens, you're not going to speak up. If we allow food on the floors, you say, okay, our policy has no food on the floor. We allowed food on the floors and we see infections. That's it. What do we tolerate, basically, is what we promote. So we can say anything in the world, but if we tolerate it, that leads to a culture of safety. And then how do you balance, and we'll get into this in the safety algorithm. Many times when things go wrong, our first response is to punish. And part of the reason why we don't speak up is we're afraid of being punished. Because we've grown up in a reward environment where if you're the best student and you do the best, you're going to get rewarded, and anything short of that is a punishment. But for patient safety, it's really important to separate out holding people accountable versus punishment. And that's something that comes up all the time. And there's some time when you've done something so egregious, it's your egregious behavior that led to harm. That's punishment. But most of the time, I would say 90% of the time, is system factors. And you can't, if the system is responsible, you can't punish when the system's responsible. So now we have a case, and I want you to read it. And there's two things you have to do here. Decide if this is a near miss or an adverse event, first of all. And then can you identify all the factors that contribute to the near miss or the adverse event? Now, when you're doing a diagnostic review of a case, it's just like if you have a patient. And so what I want you to go through is read this case, and then with a pen and paper, write down all the problems, just as if you're writing down all the problems on a patient. What were all the things that went wrong here? And spend the time doing that, and then we'll go to the next step.
Case 1. Pat, a third-year medical student, is on call. It's 2 a.m. Pat's on call with Jason, an intern, and Jessica, a second-year resident. Pat just finished performing a history and physical on a newly admitted patient. She's just about to sit down and start writing the H&P when Jason walks by. He looks exhausted, Pat thinks. She asks, "Hey, Jason, do you need any help?" Jason stops. "Oh, yeah, I have to put a central line in one of our new patients. Do you want to help?" Pat's excited. "Yes, I've never seen one done before." On their way from the atrium to the tower, they stop at ABP for a coffee. Jason tells Pat he was out late last night with a few friends and only had 5 hours of sleep. "I can handle it as long as I get some caffeine," he says. As they continue walking, Jason is paged twice, once by the nurse who's waiting for them to insert the line. They arrive on the tower unit. Nurse Kathy is waiting for them with a central line cart. "Where's your senior resident?" she asks Jason. "She's tied up with another patient. I'm going to get started with the line. I've done it before." He walks in the patient's room and sets his coffee cup on the table. "Hey, Mr. Stark, we're the on-call doctors. We need to put a central line in your IJ. Is that okay?" Jason turns to Kathy. "Why is he on a portable monitor?" Kathy says she's not sure. There was an order for it. She's a recent graduate, and this is her first month at the hospital. They position the patient for the procedure. Jason prepares the site with chlorhexidine. He checks the ultrasound machine but finds that it doesn't turn on. He curses and tells Pat it didn't work the last time either. He puts his gloves on and starts the procedure. Several minutes into the procedure, Kathy reminds him, "We're supposed to do this checklist for central." Jason, who's having difficulty advancing the guide wire, interrupts. "I can't do that right now. It'll have to wait till I'm done." Pat is getting uncomfortable. "I was totally freaking out," she later tweets to her friends, as Jason seems to be struggling and there's a lot more blood than she expected. They will later learn the patient has had complications with prior central lines at the same site, and that the patient was taking clopidogrel at home. "Maybe we should call Jessica," Pat thinks, but she's afraid to say this. Jason tells her to put gloves on and apply pressure. They make several more attempts at securing the line for the next 15 minutes when Kathy glances at the monitor. The heart rate icon is flashing 0, but there is no audible alarm.
All right, you should have gone through this case, identified all of the factors that went into this case, and now we're going to do a deep dive into this case. But before we do this, I want to just show you what's called a fishbone diagram. You see this looks like a fish with harm is in red on the right, and those factors, 6 factors that we raised before as boxes here with little lines underneath them. And one of the we use this as a process to understand root cause, why did harm occur, and what are the contributing factors to root cause. And so one of the things we're going to do with this case is apply all of the factors you identified. and put them in these categories to go through and understand what went wrong. So let's talk about what happened. In this case, there were errors, technical as well as decision-making errors. And there was harm, in this case, to the patient who died. So this was a case with harm. And I will tell you something in these cases that's always true. When harm occurs, you can always find about 8 things that have gone wrong. It's never just one thing that goes wrong. There are many things that go wrong. Generally, one mistake or one slip, one error will not lead to harm. There are sometimes one mistake can lead to harm, but usually there's multiple factors that go into harm occurring. It's very easy to think about blaming or punishing Jason or even Jessica for not supervising and Kathy for not going up the chain. We can also rationalize and say, well, this is an expected complication. We hear that many times. Something happens to a patient and say, well, it's one of the complications. Yes, but should have happened. They'll say, well, these things happen as we take care of very sick patients. So what's the problem with these approaches? First, Jason and Kathy and Pat are probably devastated by this experience and feel personally responsible. If you think about all of us getting into what it takes to be a doctor, it's a winnowing process of the smartest people ever. And so when you get to medical school, you're like 1 out of 100 who ever took organic chemistry. And so we think that we can do everything with our brains and our smarts. And when something happens, it's devastating to all of us. Second, anyone can make the same errors. Third, there are things we can learn from this case about our system of care. By blaming or rationalizing or punishing, we miss the opportunity to improve care for the next patient. So this is why we want to report near misses and adverse events. This is so we can learn as an organization. So not only that, we should say, hey, this happened today. We want to let everyone in the organization know it so you can prevent it. We should broadcast these. Errors and policy violations are often treated as root causes of adverse events, but this is a flawed view. What turns out to be an error in hindsight either seemed personally reasonable to the staff or wasn't detectable in real time. No one says, I want to kill a patient today by putting a puncturing them, or I'm going to mark the wrong surgical site. We have to understand why the error occurred and why it seemed reasonable at the time. We had a situation where there was a wrong site operation, and because there was a marking, and the surgeon left the room at the time and came back in, and there was another marking, and the conversation was left, right, and it was left. Instead of saying left, right, you could say there's confusion even in our words. And the operation occurred on the wrong side because someone said left, right, and they let the words go. And in that conversation, you could see how things get mixed up. In complex systems, errors are bound to happen. Our job is to understand when errors occur, report them, but prevent harm from occurring. So let's go to this case now and look at the details. So this is the how the factors been laid out by me here. Human factors were a sleep-deprived intern. Kathy was an experienced nurse. Loss of situational awareness, what's going on to the patient. The pulse dropped to 0 and people weren't paying attention to what was happening. Task fixation. So one fixed on getting the task done wasn't paying attention to the other things. Imagine what it's like to say, I'm going to do this, the huddle, the idea before an event, doing this idea of a timeout, and people having clear assignments of what they're going to do. So you monitor the patient and the monitor. I'm going to put this in, the device in. You can see how just organizing yourself differently around the same event might have done better. System process design, the ultrasound machine wasn't working. The alarm wasn't audible, with the volume to ask why. So here's another key to root cause analysis, and it comes from Lean Toyota. Ask why 5 times. Why? So the ultrasound machine wasn't functional. Why wasn't it functional? Uh, well, it's going to get down to some process or procedure of how ultrasound machines are checked. The monitor didn't have audible tones. Why was it turned down? And why did it need to be turned down? You ask why 5 times, you can often get to the bottom of this. Administrative controls. Jason wasn't being supervised. We don't know if they received training. Pat should not be tweeting her friends around care. Was the patient consented for the procedure? Hazards. So the central line catheter was a hazard. The patient was on Plavix. You'd want to be able to say, in a structured system where we have lots of blood thinners, is the patient on a medication that could cause harm before this procedure, right? If that's in your mind to ask and not on the checklist beforehand, and maybe that the checklist isn't correct. So would you like your checklist to say, if yes, pause. Was there indications? A lot of times you say we do things, but are there clear indications for it? Could he got a peripheral line? Did he need a central line? Patient factors, thrombosis from a prior line insertion that could have known. Patient was taking Plavix at home, and culture. The big thing is the culture of safety. When someone senses or has a concern, stopping the line. Say, we're not going any further. Stop. I have a concern. Raising your hand. It could be the culture that the broken machine wasn't reported, or the alarms don't get checked every day for volume. And so those are culture. Culture is huge at correcting behaviors. I give the example of culture of crossing the road through the white lines or on the crossing. As a little child, you learn that, and your mother or father makes you cross the street and look both ways. And then they correct you for doing that. And now as adults, we go to the curb, we look both ways, and we cross the street. It's not like there's a policeman making sure you're crossing that. That's culture at work. And we're all part of the healthcare culture, and what we do every day creates the culture for other people. So that's a huge part of our personal behavior around the culture of safety. Okay, we're going to another exercise here, and this is which of these going to 3 cases. Which of these is an adverse event, a near miss, or an unsafe condition? A medication for seizures is ordered for a hospitalized patient. Before giving the patient, the nurse asked whether this patient has seizures. The intern realized the medication order was meant for a different patient. So, is this an unsafe condition, a near miss, or an adverse event? Well, it's not an adverse event because the patient didn't get the medication. Thank goodness the nurse asked. It's definitely a near miss. But you could say it's potentially even an unsafe condition there. We just don't know. How the conditions allows the resident to order medication. This happens all the time without knowing what the condition is, and so it may be an unsafe condition and a near miss. An antibiotic is ordered for a hospitalized patient. Before giving patient medication, the nurse wonders, but doesn't ask whether this patient has an infection. The patient receives 1 dose of medication meant for a different patient and has an allergic reaction to it. Well, harm occurred, so it's an adverse event. But it's also probably an unsafe condition too, because there's not a system of checks and double checks in this that the patient could receive it. The elevator is used for transport patients from the post-anesthesia recovery unit to the ICU are not working. So this is an example of an unsafe condition. But it needs to be reported as well as unsafe condition. We actually had this at Rush, where an elevator was broken for a long time, and these elevators misfunctioned, and there was a child on ECMO coming from the operating room to the pediatric ICU, and the elevator was misfunctioning. We actually did root cause analysis on no harm to the patient, but a serious unsafe condition leading to a near miss led to a root cause analysis, which led to the immediate fixing of the elevators. So you can see buildings are unsafe conditions or near misses as well that can get in the way of patients and safety.